Oh. So this will be the last talk before we get to be together and brainstorm again, and hopefully wrapping it up in terms of thinking about clinic and insurer level barriers and some of the proposed solutions that we had coming into this conference that we will add to all together and maybe prioritize. So positionality. I think that this talk is with the position of trying to get to as many patients as we can get to. So certainly there are different perspectives from the insurer standpoint, from the clinic standpoint, from the clinician standpoint, and from the patient. So this talk is really with how are we going to best improve access for that patient. From the work that we and others have done, this is how I view it, is that the fertility preservation benefit mandate starts on the left as being a perfect square of what it is what we wanted, and it's dark and it's blue. But then it gets implemented through our regulators, so it gets a little bit lighter. It gets implemented then through the insurer, so the product of what happens after regulations is insurer interpretation gets a little lighter, and then it gets to the clinic, and the clinic has various ways of implementing or not implementing access, so it gets like the shape is changing, so that ultimately when we get to the patient, it's kind of this amorphous, differently shaped fertility preservation insurance benefit than maybe what was intended in the first place for them. So our question for this short talk is for insurers and clinics, what do we find as key barriers for using insurance to cover fertility preservation services? Kara and Sarah talked a bit about the process. And so I thought it was easiest in my head to break it down as from the insurer standpoint, you've got to design fertility preservation benefits. You have to contract with fertility clinics in order to have enough networks to work with. You have to be able to configure the benefits within the coding systems inside the insurer. And then you need to communicate the benefits with everybody else, your members, your clinicians, your regulators, and how to utilize them. So there are some barriers and facilitators that we saw and some suggestions for what would be optimized outcomes from the patient standpoint. So mandate clarity, we talked about already. What is the scope? That it should be at parity with other medical services. So you're not paying 50% coinsurance for this, but much less coinsurance for some other medical service, for example, for cancer. And then prior authorization is a big part of the delay that can happen. Purchaser preferences are a barrier because every employer might have different ideas of what it is they want to pay for, and they're just adding work for the insurance plans and making it very heterogeneous what the benefits are, and therefore hard to understand. And then the champions that we have at insurance plans are gold. Whether it is the champion at the prior authorization unit, which Shannon and Pam know, to individuals who are designing benefits. So our thoughts are optimally a fertility preservation benefit should be comprehensive. It should cover every piece of a fertility preservation service that you need in order to ultimately get to your outcome of a healthy mom and a healthy baby. It should be at parity with other medical services for affordability, and we should try to lower the threshold for being able to access the benefits. In terms of contracting with clinics to have an adequate network, fertility clinics are often not in big academic medical centers. And so you have very limited resources for contracting. And so there's a network adequacy issue. So whatever can be done to optimize these contracts would be great. Configuring fertility preservation benefits and coding systems is that these services are often not found or as uncovered services and coding systems. And that's kind of a black box I think I haven't figured out. It feels like it's tucked under infertility diagnoses and therefore maybe not related to cancer diagnoses. And so if you start off with no infertility benefits, it's a hierarchical system, then potentially your fertility preservation services are therefore not covered because it's not related to the right diagnosis code. So optimally, we would like to see reduced time for benefit verification, prior authorization, and claims if the configuration inside the insurer for coding could be optimized. And then the communication, training your frontline member and provider services to understand that this benefit is a distinct benefit from infertility and that it exists. And having benefit specificity, like what Shannon showed a little earlier for that really nice plan, to say what is or is not covered. So it's not confusing. And that should be both on the provider portal and on the member portal. And so if you could have efficient and accurate determination of fertility preservation benefits that exist and for which patient and to what extent, that would really save a lot of the time and heartache that some of our patients and our clinicians face. How many minutes do I got left? Okay, great. So thinking about it from the clinic standpoint, what do the clinics have to do? They have to contract with insurers. They have to provide insurance and philanthropy navigation. They have to have knowledge of what the fertility preservation benefit mandates say, and they have to monitor implementation for financial support of fertility preservation. So I'll walk through each of these in just a little bit of detail in this very short amount of time. In order to contract with insurers from the clinic standpoint, you have to have acceptable negotiated rate. The clinic personnel and has an expertise to be able to do the insurer negotiation. And if you are small, not large networks of fertility centers, you may not have that expertise to negotiate in your favor and therefore decide not to do it. And you, again, need a champion. And optimally, you want to be in network across all insurance plans within the same carrier and across carriers for patients, kind of like what the Columbia model looks like. In terms of insurance and philanthropy navigation, there's really limited expertise and resources for benefit verification, prior authorization, claims, appeals, and patient counseling. And so sometimes we think about whether it can be more centralized, taken out of individual small mom and pop fertility centers to something that is more accessible or shared, and support financial counseling and insurance navigation. Knowledge of fertility preservation mandates. I don't know how many clinicians say, and particularly our oncology colleagues, how happy we are that this benefit passed and carry this mandate passed and carry this on as a message to their patients, when actually you saw time and again, it's a small segment that are subject to this law. So there's very limited both clinic and patient health insurance literacy. So we want to be able to efficiently determine which benefits exist for which patients accurately and to give patients self-efficacy. And Erica Crable will always say that you have to have sustainment. You have to look, after all is said and done, long-term, should our current practices continue, is it successful, and fix it if it isn't. So audits and adaptations of the processes to support fertility preservation access. So this is a short slide, again, to sort of, we realize we're teasing that we have this toolkit, but we do have this toolkit. We should have distributed it before. And then so this essentially goes through the background of fertility preservation, the different mandates, kind of what they specify or don't specify, our recommendations for mandate legislation, health insurance regulator work, health plan work, oncology fertility clinics, and patients. And this is the appendix that Joyce talked about earlier for patients. So I'm out of time, but my recommendation for clinics is to be able for all of us to jointly figure out what are effective clinic strategies to help clinics and patients access benefits, and how do you scale it beyond large academic medical centers? And the questions are, what are the strategies that are effective, and how do we scale it? For insurers, compliance with the mandates with the goal of equity and fertility preservation access. And my questions are, what policy levers will move compliance? Thank you.